Hideki Mochizuki from the Department of Neurology, Osaka University. It is a great pleasure for me to have a seminar in IAPRD 2021. The title of the talk today is Gene Therapy for Neurotrophic Factors. This is COI slide. For gene therapy, there are two methods to deliver the gene into the human body. One is the in vivo gene therapy using virus vector by direct injection. Another one is the ex vivo gene therapy by autologous transplantation of gene-corrected cells. In general, there are two types of gene therapy techniques. First is the replacement with normal genes into genetic disorders, such as metabolic disorders or familial Parkinson's disease. Second is the introduction of gene drug into non-genetic disorders, such as cancer, AIDS, or sporadic Parkinson's disease. In gene therapy for Parkinson's disease, there are two approaches, the symptomatic and disease-modifying approach. As a symptomatic approach, TH, AADC, and GCH1 are candidate genes for the enzyme replacement strategies. There is also another approach aiming at modulating STN activity by delivering the gene glutamic acid decarboxylase, GAD, the rate-limiting enzyme for the synthesis of GABA. As a disease-modifying approach, neurotrophic factors and genes are based on the genetic causes of PD, such as GBA, Parkin, or PINK1 are employed. My talk today will focus on gene therapy using neurotrophic factors. First of all, I would like to briefly talk about the glial cell line-derived neurotrophic factor, GDNF. GDNF was discovered in 1993. GDNF promotes survival and regeneration of mature dopaminergic neurons in vitro and in vivo. It binds and transduces the signal through multiple receptors, RET, NCAM, N-cadherin, integrin. So in a paper published in Nature in 1995, Tomac and colleagues indicated that intracellular GDNF administration exerts both protective and reparative effects on the nigrostriatal dopamine system in MPTP-treated mice. In 1997, Dr. Mandel and colleagues reported that midbrain injection of AAV, A-coding rat GDNF, protects nigral neurons in 6-hydroxydopamine models. Rats received nigral injection of either AAV GDNF virus or AAV LAC-Z control virus 3 weeks before a striatal 6-hydroxydopamine lesion. AAV GDNF protects against cell death from 6-hydroxydopamine toxicity. In 1998, I collaborated with Dr. Maral Bodarian from Tom Chase lab at NIH. Injection of GDNF expressing encapsulated baby hamster kidney cells into 5 MPTP monkeys was performed by the same blinded investigator. So they found a subtle motor benefit was observed in this trial. So indeed, I was responsible for the neuropathological evaluation of Th cells in all groups. So this is the most important part of this study. However, unfortunately, Th immunoreactivity in the substantia nigra showed no consistent recovery. So histopathological studies also revealed an intense inflammatory reaction with mononuclear and multinucleated giant cells, as well as gliosis around each implant site. So this is the negative study. This was published at 2003. It took 5 years for the publication. Next, I will introduce several clinical trials of GDNF. In 2003, Dr. Nutt and colleagues recorded a multi-center randomized double-blind placebo-controlled study of intraventricular administration of GDNF recombinant protein for PD patient. They reported that changes in UPDRS were not significantly different in each group. They also indicated that anorexia, weight loss, paresthesia, and Lermite phenomenon as the adverse effects. Another trial was the open label study of continuous intraabdominal injection of GDNF using a pump for PD patients. After a year, there were no serious clinical side effects and a 39% improvement in the off-medication motor subscore of UPDRS and a 61% improvement in the activity of daily living subscore could be observed. So however, this is a phase 1 open study. They later proceeded to a double-blind study. So this was phase 1-2 multi-center randomized double-blind placebo-controlled parallel group study to evaluate the efficacy and safety of intraabdominal infusion of GDNF in patients with idiopathic Parkinson's disease. So unfortunately, the changes in UPDRS were not significantly different. So however, the PET component of this study demonstrated a 23% increase of posterior putamen for dopa influx constant in GDNF group. They also reported clinical and PET evidence of persistent efficacy lasting for at least 3 years following cessation of GDNF infusion in a patient with PD as a case report. So they then created a new system, which is the intermittent intraabdominal convection enhanced delivery via a skull-mounted transcutaneous port for the delivery of GDNF. This single-center randomized double-blind placebo-controlled study was reported in Brain 2019. 35 patients received bilateral intraabdominal infusion of GDNF or placebo every 4 weeks for 40 weeks. However, the changes in UPDRS were not significantly different. So next, let's move to neutrin. In 1996, neutrin was discovered as a relative of GDNF. Neutrin signals to the cells via the RET receptor, but its binding to RET is mediated through the GFR alpha-2 co-receptor. Nutrin promotes survival and regeneration of mature dopaminergic neuron in vitro and in vivo. This slide is about the open study of gene therapy for AAV2 nutrin to patients with sporadic Parkinson's disease. In this phase 1 open-label clinical trial, 12 patients with PD diagnosis received bilateral stereotactic intraabdominal injection of adeno-associated virus serotype 2 nutrin. The first 6 patients received doses of 1.3 times 10^11 vector genomes per patient, and next 6 patients received 5.4 times 10^11 vector genomes per patient. So the initial data support safety and tolerability. So this figure indicated the recovery of UPDRS, but this is just an open study. So they later proceeded to the double-blind study. This slide shows the multi-center randomized double-blind placebo-controlled phase 2 study of bilateral intraabdominal injection with high-dose AAV nutrin for PD patients. Patients who received AAV2 nutrin did not show significant improvement for the primary outcome measure at 12 months compared with those who received sham surgery. Histological analysis was done on the brain of patients who were treated with AAV2 nutrin. Staining for nutrin protein covered around 50% of the target putamen by volume, but only isolated nutrin deposits were detected in melanin-containing neuron in the substantia nigra. The result indicated that this approach shows the difficulty in delivering nutrin into the substantia nigra. Next, they tested the safety and efficacy of AAV2 nutrin delivered to putamen and substantia nigra. So this is a multi-center randomized double-blind placebo-controlled study. So 51 patients were enrolled in this trial. They treated AAV AAV nutrin into the bilateral putamen and substantia nigra injection at the same time. So, however, there was also no significant difference between groups in the primary endpoint or in most secondary endpoints. A post-hoc analysis suggests that greater benefit are observed in the subgroups of patients who were evaluated less than 5 years after diagnosis. These suggested that it might be necessary to recruit patients at an earlier stage of disease in future studies of the neuroprotective therapies. So next, I would like to introduce the ongoing AAV GDNF study. So this slide shows the phase 1 trial to assess magnetic resonance guided intraabdominal injection of a high dose of the AAV GDNF therapeutic in a moderately advanced PD patients. At the same time, gadolinium contrast agent was co-infused with AAV GDNF. AAV2 GDNF was tolerated without clinical or radiographic toxicity. At the 18 months post-operative PET scan time point, 12 of 30 patients showed increased flow dopa Ki values bilaterally compared to baseline. So regarding GDNF in PD, they are almost done with a phase 1B trial in PD patient. And they're starting same in MSA subjects, collaborate with ASK Bio. So this slide shows AAV2 GDNF gene therapy for multiple system atrophy, MSA. This is the information from a clinical trials gap. The objective of this randomized double-blind placebo-controlled phase 1 investigation is to evaluate the safety and potential clinical effects of AAV2 GDNF delivered to the putamen in subject with either a possible or probable diagnosis of multiple system atrophy. So they started from January 2021. So they will enroll 9 MSA patients. So this slide shows the recent advances of neurosurgical gene therapy delivery by a review from Professor Bankiewicz group. So the use of intraoperative MRI allows visualization of the accuracy and adequacy of viral vector delivery within target structures. So this facilitates intrastriatal modification in surgical approaches, canal design, vector volumes, and dosing. A reflux resistance delivery cannula with a stepped design was used to increase distribution within the target putamen while reducing off-target leakage. Furthermore, switching from the use of multiple transfrontal trajectories to a single parieto-occipital shape conforming infusion and increased infusion volume have significantly improved target putaminal coverage. So similar to the surgical strategy used to increase putaminal perfusion volume in the recent AAV2 AADC trial, a phase 1B trial is enrolling PD patients for AAV2 GDNF infusion that employs an occipital approach with convection perfusion along the long axis of the putamen. So next, I would like to introduce this paper published in Movement Disorder at 2020. These are excellent experiments. So this paper indicates that AAV-mediated overexpression of GDNF in vivo prevents accumulation of alpha-synuclein aggregates in the substantia nigra. So using alpha-synuclein preforming fibrils striatal injection mice model, these effects were abolished by deletion of receptor tyrosine kinase rearranged during transfection or by inhibitors of corresponding signaling pathway. So they show the neurotrophic factor mediated protection against the misfold alpha-synuclein propagation in dopaminergic neuron in vitro and in vivo. So this was very important information before starting the MSA clinical trial using AAV-GDNF because, of course, MSA was one of alpha-synucleinopathies. Besides GDNF and neutrin, a new protein known as cerebral dopamine neurotrophic factor, CDNF, has recently entered clinical trials. CDNF and its relative mesencephalic astrocyte-derived neurotrophic factor, MANF, form a novel family of unconventional neurotropic factors. These are both structurally and mechanistically distinct from other growth factors. CDNF and MANF are primary ER lumen-located proteins with potent cytoprotective properties in multiple cell types and tissues. CDNF was shown to protect dopamine neuron from alpha-synuclein oligomer toxicity in vitro. And also intraputaminal administration, intraputaminally administered recombinant human CDNF has shown robust neurorestorative effects in several small and large animal models of PD and had a good safety profiles in preclinical toxicology studies. The first in-human study with CDNF, sponsored by Harentis Pharma, has started in 3 centers in Sweden and Finland in late 2017. In this randomized placebo-controlled interventional multi-center phase 1-2 study, 18 patients with idiopathic moderately advanced PD were enrolled. Monthly infusion of CDNF were given for 6 months. A neurosurgically implanted during a drug delivery system, essentially similar to the one used in Bristol GDNF phase 2 study, was used for intermittent intraputaminal delivery of CDNF. Top-line result from the first part of this study showed that CDNF was safe and well tolerated. In some patients, promising responses in dopamine transporter PET imaging, which measures dopaminergic function, were observed. The promising results seen in the trial first part have prompt plans for a future phase 2 trial, which will assess the effect of longer treatment with CDNF patient in an earlier stage of Parkinson's disease. Patient enrollment is expected to begin in this year. So they also recently discovered that certain smaller fragment of the CDNF protein maintains the neuroprotective and proteostasis modulating activity and can also pass the BBB as X-CDNF. So they will start the clinical study using X-CDNF. So these results imply that CDNF gene therapy can be one of the candidate therapeutic therapies for Parkinson's disease and related disorders. So this is our final slide. This is a take-home message. So GDNF has the effect on promoting survival and regeneration of dopaminergic neurons. This has led to a series of clinical trials in PD patients, including using infusion or gene delivery of GDNF or the related growth factor nutrient. Initial open label studies suggested that this approach could be of value in PD when the agent was injected into the putamen rather than the cerebral ventricles. In subsequent double-blind placebo-controlled trial, treatment with GDNF and nutrient did not achieve its primary endpoint. The development of MRI-guided CED has allowed real-time monitoring of vector distribution within target structure, leading to improved vector delivery. As a new clinical trial, GDNF gene therapy for MSA has just started. Thank you for your attention.